Yes, you can start, Dr. Kotikian.
Okay, wonderful. Good evening, everyone. I'm going to welcome all of you to our combined dental and medical CE talk for this month. Just want to remind everyone that everyone will be getting 2 CME for their medical providers and 2 CDE credits at the conclusion of this lecture. We have the honor of having Dr. Padilla, who is a professor at USC. I actually teach right next door to her at the oral surgery clinic. So she's going to be giving a lecture on temporomandibular dysfunction and facial pain. Dr. Padilla completed her dental school in 1989 at the University of Costa Rica, and in 1998 completed her residency program in orofacial pain at UCLA. I actually happened to be there when she was a resident, but I was in class at the time, not in the clinics. In 2005, she obtained her master's degree in education and curriculum design, and eventually was appointed the Dean of the Latin American University of Science and Technology School of Dentistry in 2005. She practiced general dentistry, and for the past 5 years, she has been at the USC Orofacial Pain Clinic. So I'd like to welcome Dr. Padilla. I'll hand over the mic to you. Thank you.
Thank you very much. Thank you, Armond, and thank you everybody from the Armenian American Medical Society. It is my pleasure to be with you today, and I hope that we will have a very good time sharing and talking. I will be exploring some clinical-oriented tips for discovering or understanding better some situations that might look like dental pain that probably are not, probably are more related with other conditions. And we like to say TMJ or TMD as an umbrella term, but I'm going to try to cover other diseases or conditions as well. And to do so, I will be basing my presentation in 3 clinical cases, completely de-identified, but I think that will help us to discuss the topic. There will be some time to share questions, and I never like to say answers. I will say suggestions or my intake from some of the topics. And I would like to remind the audience that we do have a streaming happening in Facebook Live. So you can stream if you like. And I understand that the presentation will be then uploaded into YouTube from the society. So feel free to use the material, and to take advantage of the information that we're providing for you today. And hopefully this will be an useful experience for all of us. I'm going to share my screen now, and I want to show you a couple of details that are available here. One is my email address. So feel free to email me at any given time. So this is my email address, Mariela, letter P as my last name at usc.edu. And I'm also providing here my ResearchGate user, because most of my actual research is there for you to take a look if you are intrigued and want to explore a little bit more about things that we have been publishing in our department. I have been in USC for 5 years now, and I am the assistant director of distance learning. We do run several certificate and master programs online. We are almost ready to launch the new one, so we will have 11 next month. And we have been teaching online since 2003. So we do have experience teaching as a department, as a team. But the last year has been super interesting because we had a unique opportunity, as many of you, to embrace change, to discover ourselves, and to see what else we could do to make this a better world. And one of the things that definitely happened is that most of us got very familiar with teleeducation. So now for us, it's common to connect in Zoom or to stream a lecture or to watch it in YouTube later, or even to podcast and listen to the as a standalone audio files. So I'm very happy to be part of this, and I'm very happy that all of you are here with me today, because that means that we're on this together. And because we're in this together, I understand that we all want to make this a better place to live. The career choice that I made was dual. In one side, I want to be able to help people with pain. So when I say that I'm a pain specialist, it's not because I produce pain. It's because I try to bring proper care to people who's in pain. Hopefully, most of the time, I can help them to relieve completely from that situation. Sometimes we just help them to get into a functional state and being able to function properly in the environment. My second choice was to be a teacher, and I do like to teach, and I feel like I learn more as I teach more. So in a way, for me, teaching is a little bit selfish because it's my way to learn more myself. The lecture today is based on a statement from the International Association from the Study of Pain. That was a long time ago in Geneva in 2004, and basically said the relief of pain should be a human right. And I love that. It's not something that is there like granted. It's something that people has the right to have. And because of that, we as clinicians, we have the responsibility to provide. So part of the care that we have to provide is to be sure that we don't produce pain, or if the patient has pain, that we will be able to relieve that. And that will be my purpose for the day. I have to be honest with you, and I have my streaming on a second window here, so most probably I will not be able to see your questions live, but I have Dr. Armond here, and he will be in charge of being sure that I address all the questions at the end. So I apologize that most probably I will not be able to address your questions immediately, but we will have some time at the end. Now, when we talk about orofacial pain, it's beyond temporomandibular disorders. When we talk about orofacial pain, we're thinking on different possible situations that might be producing pain. And of course, it's beyond dental pain. So I hope that I have in my audience a very good group of dentists, and we do understand that probably the most common reason why the people will visit us as dentists is because they have pain on a tooth, or hopefully because they want to do a regular dental cleaning. But orofacial pain in reality goes beyond that. And there are several classifications available for us. And the classifications are very important because as soon as you decide what is the diagnosis that you're going to provide to that patient, the treatment is basically a protocol. The technique we have, the different procedures we understand, we know how to perform them. But when that selection is key in managing pain. So there are at least 3 classifications that I want to mention today, and there are more, but there are basically 3 that I wanted to mention today. The first one is the International Headache Society classification. This comes from the medical world, and I again understand that many of you are doctors, or are MDs, so I have a group of MDs here today. The international classification for headache was, the last publication is 2018, and it has a basic 1, 2, 3 that I like a lot. Primary headaches, and there we are going to include migraine headache, tension type headache, and the trigeminal autonomic cephalalgias. 3 big groups, okay? Then we have a second group or a second category of classification that is secondary headaches. And over there we have, for example, sinus-related headache, temporomandibular disorder-related headache, dental-related headache, and even intracranial problems producing headache. Also, in secondary headaches, we have all the metabolic conditions that are related or that will produce as a symptom headache. And the third category is the one that I want to point out today, is the painful cranial neuropathies, facial pain, and other headaches. So everything goes together there on the third category. And we will discuss today what is a neuropathy in the orofacial pain area. And inside the facial pain category, I will discuss a little bit about muscle pain and, of course, joint pain. The second category or classification that I have here in yellow is the ICD codes. This is the version 11, even though most of us are usually International Classification of Disease in version 10. But here I have the codes from the version 11, and I'm just putting some examples here for you to get familiar with them. This classification will give a code, and the code is important for billing purposes, and each one of the codes has a descriptor. For example, if the patient has pain in the jaw, we will say that the patient has arthralgia, could be capsular pain, could be retrodiscal tissue pain, and in that case, we will call that an M2662. If it's on the right side, we will add a modifier number 1. If it's left side, modifier number 2. And if it's bilateral, modifier number 3. And all those numbers will be important for billing purposes. Another example is M7912. That is myalgia. But careful, this is myalgia on the cervical muscles. And I hope that today I will go over with you with some exercises. I will provide with some exercises and some ways to see if the patient has some cervical myalgia. And finally, another example is the last one, G50.8, and that will be a trigeminal neuropathy. And that is frequent when you have burning, sharp shooting sensations with a background continuous pain. And I do have a case like that for today. And the last classification that I have on this slide is the International Classification of Orofacial Pain. This is very hot from the oven because it's 2020. It was released a year ago, so it's very new. And this classification has 6 different categories. Category number 1 is dental alveolar and related structures. So very nice. They have a space for dental pain, odontogenic pain. Number 2, myofascial. So all the myalgias are here. They don't divide muscle pain in myalgia, localized soreness, co-contraction. Everything is together. Myofascial, primary or secondary. Category number 3 is TMJ pain. Again, very broad, like an umbrella term. Primary and secondary pain, and we will discuss one case of osteoarthritis today. The category number 4 is lesion or disease of cranial nerves. So some secondary pains or secondary conditions. Classification number 5 is the same of IHS number 1 and is primary headaches. I already mentioned them. You should know them by now. And number 6, idiopathic pain, that I don't really like the term because it looks like if we don't know what is going on. But that is a basic 1, 2, 3 category that I have for you here. And I will be mentioning the 3 of them as we move forward today. Now, when we want to arrive to a diagnosis, of course, there are certain steps that we have to make, that we have to take. And I would like to say that there are 3 basic things that we have to do with all our patients during our encounter, during our clinical encounter. Number 1, we have to collect as many data as possible, but high quality data. So you don't have 3 hours to sit and just talk to your patient about life, about the weather. You want to ask the right questions. You want to get the right information in order for you to make the best possible decision. What type of data you want to collect? Of course, you want the chief complaint. You want to know why that patient is here. Why is the patient visiting you? Why the patient went to one or another doctor? What is the reason of the visit? Then you want to have a very good medical history. You want the background of that patient. You want to know what are systemic conditions that the patient has. What has been the reaction to different medications? What about surgeries? What about social history? What is that this patient does? Is the patient enjoying life? Is the patient sleeping well? So in medical history, we also have the psychosocial history of the patient, family history, the possibility of dealing with genetic disorders. And of course, during the collection of the data, you want to do a proper clinical examination. And you can examine many things, but I want to focus on several things that are very important for us. And always remember that you want to be comprehensive in your review, but at the same time, you have to be able to collect information that will allow you to find things that probably the patient is not aware that they have or that she or he has. Then the second big area is making decisions. Once I have collected the data, what else I need that I don't have? What are the diagnostic tests that I required in order to complete my information? Do I need an X-ray or any other imaging? Do I need a laboratory study like a blood test or a sleep study? Do I need to consult or to talk to someone else about this case? What else I need that I don't have? And with all of that, my next decision is what is the diagnosis that I'm going to give to this patient? And probably on the first appointment, you won't be able to filter everything into 1 or 2 or 3 diagnoses. Probably at the beginning, you will have 6, 7 ideas, but then you start narrowing it down and finding out what is that this patient has. So that will be the diagnosis process. We call it differential just because we include several things. I always like to say that I'm very good doing diagnosis because I always include something else, something that I didn't think about. So you will find out what is that your patient has, but probably not on the first appointment. And then during that decision process, per diagnosis, you have to establish a treatment plan and have a way to really, really address that situation with the patient. Finally, on this category that I'm giving you, collecting data, making decisions, the third one will be, okay, let's perform the procedure. Let's perform the whatever the treatment that I'm giving to this patient. And I'm going to do an injection, and I'm going to do night guard, and I'm going to prescribe a medication. And also consider that once you have a treatment plan and that you're rendering that treatment plan, it is very possible that you will have to realign, that you will have to fix that and look for a plan B. So always keep in mind that in orofacial pain, you need to consider that probably your first diagnosis and your first treatment plan was not covering the whole situation for that patient. We have created this little infographic here that helps to reach a diagnosis based on 5 questions. And the 5 questions you always have to do. Where does it hurt? Can you show it to me? And let me tell you that the best thing that can happen to you is when the patient uses one finger only to point. So it hurts here, it hurts here, it hurts here. Oh, that's beautiful. Very exquisite. The discrimination of the location of the pain. The site of the pain is clearly established, and usually that is a nociceptive pain, easy to find, easy to locate. But what about the patient that, well, it hurts around here. Now he's using 4 or 5 fingers and a bigger area. And come on, not even only mandible, the maxilla. Sometimes it goes up to the temple area. So is this dental? Or is this more muscle? Or what is it? Now you start thinking outside the box. Geez, beyond dental pain. And let me tell you the last one, the patient that is like, oh, it hurts around here. So they don't even point, they don't even touch the skin. It's very diffuse. And you know what, doctor? Sometimes goes to the other side. Those are even worse. So preferred pain or pains that are not very exquisite, very easy to identify. The second question is my favorite one. Can you describe the pain for me? Give me words. I tell the patient, give me words. I want words. So how is the pain? Give me descriptors. What is the quality? Is the pain dull? Is the pain achy? Is the pain electric? Is the pain paroxysmal? Is the pain throbbing? Is the pain burning? How is the pain? Give me words. And that is important because that quality gives you an idea. Muscle pain is usually dull, achy. Trigeminal neuralgia pain is usually electrical. Sometimes patient will describe like burning sensation. Throbbing or burning pain inside the mouth, burning mouth syndrome. So you start bringing possible diagnosis. I like to call this profiling your patient. As you talk with your patient, as you are doing this encounter, in the back of your head, you are starting to build a differential diagnosis. The next question is, what is the pattern of that pain? Can you describe me a regular day? What is that happens during the day with the pain? Does the pain behave differently during the day? Is it worse in the morning when you wake up? Or is it worse in the afternoon when you have been eating and talking the whole time? Because if so, it could be more functional pain. But if the pain is more prevalent when you wake up, now you're thinking, is it the joint? It was the patient clenching at night? Did the patient sleep well? Or when the patient tells you, well, it hurts at any given moment, it doesn't have a pattern. So now we are thinking, is this trigeminal neuralgia that goes and comes and goes as it pleases? So pattern is important. And then I already mentioned to you the possibility of asking for diagnostic tests and getting additional information. And finally, what makes the pain better? What makes the pain worse? So we are profiling this condition. We're understanding our patient better and better. In general, pain has the same mechanism, doesn't matter where it happens. So you usually have a source of pain and a site of pain perception. The source of pain and the site of the pain perception is not always the same. It is possible to have refer or radiated pain, and that is a little bit more complex to identify, but it is perfectly possible to have that difference between the source and the site of the pain. I'm going to show you this diagram here that is very simple. It can get complicated, but I'm going to try to keep it simple because my purpose is to present you the cases, and I just have, my time is limited, so I want to be sure that I cover that. So everything that will end in pain supposedly starts with a stimulus. That stimulus that is able to produce a painful response is called nociceptive stimulus. And I said supposedly because sometimes the stimulus goes away and you still have a pain response, a painful response. But anyhow, when you have a stimulus that is able to produce damage to the body will react because the body has to protect. The organism is meant to survive. It's meant to be healthy. So there are several things that will happen there. There will be some chemicals released on the periphery, and some examples are the prostaglandins, bradykinin, histamine, and others. And those chemicals are important in order to heal. So those are healing, the healing soup, inflammatory soup that sometimes is really, really needed. And the next thing that happens is that there are some receptors in the nerves that will receive that information, those chemicals, and will start thinking, gee, something is going on here. We need to let everybody know. So the receptors will get those chemicals or those changes that are happening in the periphery and will start an action potential, an electrical activation. It doesn't stop there because the nerve will also respond and will say, come on, this periphery needs to heal really fast. So I'm going to contribute a little bit and will release its own chemicals. These chemicals released by the nerves we call neuropeptides, and two examples are CGRP and substance P. Interestingly, those additional chemicals that are being released by the nerve will activate the vessels and will change the endothelium to open, to be more, to change permeability, and will even release more and more chemicals. So now we have like a dancing party there with a lot of substances that at the end, what are doing, they are activating the nerves. They are activating an action potential that will travel through the nerve and enter the spinal cord. And I'm jumping over the trigeminal ganglia because this model works for any place on your body. Once that information enters the spinal cord or enters the central nervous system, there are some modulation elements. They are called interneurons. And the interneurons are very important because they try to reduce the stimulus. They try to reduce the volume, the intensity of that information in order to be able to respond properly. Also, you may have a reflex, and that reflex is important to get away from the painful stimulus if that is possible, not always is. After that, the information will cross over and will go in an ascending pathway to stop on the thalamus, where some of the memories are stored and some other things happen. But interestingly, after that, goes to the cortex, and from there we will have the response. Now, pay attention to a little detail here. There is a descending pathway as well, and that descending pathway can be activated in different moments. Even when the stimulus start, we can activate the descending pathway because that pathway is mediated by several chemicals. Some of them are serotonin and noradrenaline. And those chemicals are very important because they are able to reduce or even to block the painful response, even before that information reaches the cortex. So releasing proper amounts of serotonin and noradrenaline is important because it will help you. So a person with a high anxiety or high stress, they cannot react properly to a painful stimulus. So we need to talk slowly. You need to be, to have a proper presentation, a proper environment, an environment to heal, not environment to produce more stress and more pain. And then, as I mentioned to you, the response is pain. Now, so many things can go wrong in this mechanism, and it's not my purpose to go on detail because I want to go over the 3 clinical cases, but I hope that you will have on your mind this basic mechanism of pain. Now, I did mention that today we were going to talk about beyond orofacial, beyond dental pain, beyond odontogenic pain. Because dental pain is very particular, and thanks God, usually easy to identify because the patient has a very clear understanding of where is that the pain is being produced. And something that happens also with the dental structure is that very frequently is related with inflammation. So the dental pain has that tendency to be more throbbing, even though could have all the different characteristics. So I'm going to go beyond the dental pain today. We could discuss dental pain, but that's not my main expertise. You will have endodontic people to talk about that. So I'm going to try to talk with you is what else can be going wrong when the patient is pointing to the facial area and you have decided that this is not dental pain. What are possibilities? So I'm bringing for you today 3 cases. One, where the reason was neuropathic by nature, so the nerve was behaving wrong. Muscle by nature, where we have referred pain. And of course, we had to include a case of a temporomandibular problem. And I have selected for today a joint problem. Let me check the chat just to be sure that I have nothing here and nothing here. Okie dokie, we will keep on time. Let me say hi to Noreen Danielian, who is there on the audience. Hi, Noreen. And let me say hi to people from Costa Rica who's visiting us from our chat. And thank you everybody for being with me today. All righty, cases. I know you want to see the cases. Case number 1. Case number 1 is a 52-year-old healthy male. The tooth 19 was extracted. So that's a lower first molar. It had a root fracture. When the extraction was done, was very traumatic. So it was a difficult extraction. We are not sure if the tooth was extracted because the patient had pain before, because we didn't get that from the history. Patient was focused on the pain is there after the extraction. This was produced by the extraction, but for some reason they extracted that molar, right? Patient had persistent pain in that edentulous area. The level of the pain was 5 to 6/10. He was told maybe an implant might help. That is not right, and most probably that was not exactly what the dentist meant with that. Maybe was thinking to give him proper support or something, but that was the description of the patient. I'm just telling you what the patient said. After the implant was restored with the crown, the pain was even increased and persisted. And the patient, look at the descriptors, look at the quality, dull, achy. Geez, is this muscle? It's weird, huh? weird description. However, the pain also goes in the lateral portion of the tongue, and the patient was prescribed anticonvulsants and tricyclic antidepressants, thinking that probably this was mostly related with nerve pain. So the quality sounds like muscle, but at the same time, seems like could be that there are some features that are related with nerve pain. This is a mapping of the area. How we did the mapping? We did the mapping using a Q-tip. The Q-tip behaves as a soft stimulus that will activate the A beta fibers that are not supposed to produce pain to see if those fibers behave as C fibers that are supposed to produce pain. Am I making sense with this? Let me share it with you that one very important tool is to have a Q-tip handy. Because a Q-tip, when you touch softly on several areas of the patient, intra or extraorally, should not produce pain. We're activating A beta fibers. But if the patient perceives that as painful, now you have to start thinking that that behavior is mostly a C fiber behavior. And because of that, there is a change on the phenotype of the nerve that is producing pain. And that, ladies and gentlemen, is consistent with the neuropathic pain disorder. Now, why this happened? What, is this a nerve damage? Was that the nerve transected or crushed? Not always that's the case. You cannot blame the procedure. Could be that there was some inflammation, pre-existing inflammation that induced some peripheral sensitization and that changed the anatomy or the structure of the nerves. So on those cases, probably the most important question was what happened before? Why was that tooth extracted? And now you will understand better why the A beta fiber is behaving as a C fiber, because it has been having some stimulus for a certain amount of time that is now blocking this ability of the interneurons and this ability of the modulation to work properly. So now removing the implant will not solve the problem, because now you have a phenotypical change. You need to address at the level of the spinal cord, at the level of the central nervous system, the modulation. And because of that, it does make sense to prescribe something such as an antidepressant or a membrane stabilizer that is an anticonvulsant. Okay? So yes, the diagnosis on this case is in category 3. It will be a trigeminal neuropathy with a change on the phenotype of the nerve fiber. And on those cases, once we have ruled out the dental disease and all the rest, we will diagnose this patient as having a peripheral neuropathy. You can treat this patient by using an anticonvulsant. Usually mild anticonvulsant will work. So for those of you who have experience already, you can think on something such as carbamazepine. However, remember that our patient had a background continuous dull achy pain. And those cases, they respond well also with mild anticonvulsants, such as gabapentin. The tricyclic antidepressant makes sense. It increased pain modulation. But the next tip that I want to give you is the use of topical anesthetic that will block the ion channels, and that will help a lot. So on those cases, once you have identified the area of the pain, you can actually pain the area with topical anesthetic, such as benzocaine 20%. And if that reduces the pain, I can use a stent that is not other thing, such as a bleaching tray over the area to protect that area and avoid the firing of the pain. It is perfectly possible increase serotonin using different things. Diet is one, yes, but most powerful cognitive or behavioral strategies. So breathing exercises, stress management, all of that helps. You, of course, have to treat the patient and have to treat other conditions, but yes, it is perfectly possible, and I was answering one question from the chat. Ready to keep going? Yeah? Let's go to case number 2. Case number 2 is a 45-year-old female with pain in the right lower quadrant. Right lower quadrant. So it doesn't say, it's not pointing, huh? It's moving around the area. It has 6 months of evolution. Too long. It's now chronic. It's beyond an acute pain. It has been with the patient for 6 months. Probably has been treated, but 6 months is long. And why is that important? I already told you, inhibition. Inhibition is not working anymore. Modulation is not working anymore. Now you have a pain that is also centrally mediated. And because of that, NSAIDs alone will not do the trick. You have to do something else. Now, the pain quality, let's talk about that. Continuous, dull, achy, increases with chewing. Are you with me? Does this sound like muscle pain? It does, because it's dull and achy. I already told you that, but also increases with function. So this looks more like pain related with activity of the muscles. But again, it has been with the patient 6 months. So it's centrally mediated. It's not only here. It's not only local soreness. It has something else. There's no evident dental pathology by clinical exam or imaging, and the pain is rated most of the time 6/10. So this is a continuous moderate pain per patient, huh? Proper palpation of masseter muscle reproduces chief complaint. So I have a refer pain coming from palpation of the lower band of the masseter muscle near the insertion to the front to the lower teeth. What is the meaning of proper palpation? The meaning of proper palpation is that you know where the muscle is, so you identify the landmarks. You use 1 or 2 fingers that have been pre-calibrated. So all of you will have to go and calibrate yourselves around 4 kilos. And you will do flat palpation like this, looking for the muscle. And you will also do snapping palpation like this, looking for taut bands in order to locate them. That will be a little harder. And then you stop there and press a little harder to see if the pain radiates. So proper palpation of the muscles required for you to know the anatomy of the muscle, to use proper pre-calibrated force or strength, 4 kilos. I see all of you on the grocery store now, on the veggies area, huh? And then you do some flapping like this, some snapping, sorry, like this, move back and forth. And if you find an area, you stop there and press a little bit. And patient will say, jeeps, now it hurts here, or now it hurts here. So the pain referral patterns are important. The pain referral patterns, you can have them in little cards like this, or you can memorize them. Some of them have specific patterns, but come on, patient will tell you. So just listen to your patient and the patient will tell you. Why is that important? Why is it important to know if the pain is referred? Because now the source of the pain, sorry, it's here. The source of the pain is not the same as the site of the pain. So you can do the most beautiful root canal on this molar and the pain will not go away because that was not the source of the pain. That was the site of the pain. The pain is over here. And that happens because at the level of the spinal cord, you have all this convergence, all this communication. So how do we treat this? Is it enough to give the patient an NSAID? No. Is it enough to give the patient an eye guard? No. You have to change modulation and inhibition. So you have to do something else. This condition is called myalgia with referred pattern, that is myofascial pain with trigger points or taut bands. In that case, we need to treat those stout bands or trigger points, and there are several ways to do that. One that is very important is to stretch that muscle through some exercises, and you can also do some trigger point injections. So you can put some local anesthesia into that area. And that is probably one of the most common reasons of having a source of pain that is different than the site of the pain. Some therapies that you use on these cases: thermal therapy, heat pack, very useful. Sometimes ice pack or ice cubes, rubbing the ice cube on the skin could help, but the heat pack is probably a better choice. So please go ahead and consider that. By the way, I did provide these slides, so I guess you will receive them. And most probably the letter will be very small, the font will be very small. Feel free to email me if you want the exercises. I can give them to you. They are also available on our webpage, and I'm going to share that at the end if I have the time. The stretching therapy is very, very useful for these cases because you are stretching the muscles, and the basic stretching is called N stretches. And for that, what you do is you put the tip of your tongue on the palate as when you say the letter N. And that is the position that you will use as a posture exercise or a posture position. N, my lips barely touching. And N stretches is keeping the tongue in that position, open as much as you can without separating the tongue, like this. So that's the N position, and the N stretches. Very useful for cases of myofascial pain. And finally, I did mention the possibility of doing some trigger point injections in the area. And basically what you're trying to do is to quiet down that source of pain area. Ready for case number 3? Okay. Case number 3 is a 60-year-old female with history of osteoarthritis. How do I know that? Patient describes that, but I also observe other joints. I observe the hands. I talk with my patients to understand this better. Osteoarthritis, however, could be present only on the TMJ. So it is possible that you will be the first person to identify this patient. But on this case, she did have history of osteoarthritis and was already under the care of the primary physician. Now the patient is coming with pain in the left preauricular area, 5 to 7/10. Have you noticed how I use ranges instead of one single number? Because I ask my patient, what are how is the behavior of your pain? What is a normal range during the day? I don't say, what is your pain today? What was your pain yesterday? I want a range. So I try to ask by ranges, or sometimes I ask when the pain is the worst. How high is that pain from 0 to 10? I try to avoid that question because most of the patients will tell you 10. Some of them will tell you 15. Now that pain is worse in the morning. That's an alert for arthritis. She does require dental treatment and is sitting in a dental chair. And when you start examining that patient, you find positive palpation in lateral portion of left TMJ and masseter muscle. At the same time, you found crepitus noises in both TMJ, and this is the X-ray that you have for that patient. Because my goal today is to give you as many as possible clinical tips, let me stop this to go over palpation of the condylar head. When we do palpation on the joints, we want to be able to palpate on the lateral portion of the condyle. And this is my jaw here, so I want to be able to palpate here. In order to identify where this is, I ask the patient to move a little bit in a hinge axis to locate the rotation portion of the condyle, and there I do my palpation. One finger only, around 1 kilo. You see the difference? Muscle, you press hard, 4, 1 or 2 fingers. The joint, you press gentle. Now, Dr. Armond possibly will be not that gentle as I'm telling you because he's a surgeon. And the surgeons, they want to press a little harder because they are looking for something different. But if you are a general practitioner, don't press too hard, okay? 1 kilo will be enough. Also, you want to ask the patient to open the mouth a little bit to try to palpate the posterior portion of that condyle. So when the patient opens a little bit, there is a little depression and you can palpate over there. So palpation of the condylar head is important. The other thing that you want to do is auscultate the joint because you want to try to listen for crepitus. And to do so, you use a stethoscope. Most of the stethoscope have two heads, depending on the one that you have. This is the diaphragm, this is the bell or the cup. I like the cup better, just because it's smaller and avoids the hair. And just put it over the area and ask the patient to open and close the mouth several times. So with the patient that we're discussing today, we did that, and the patient had pain in the lateral portion of the left TMJ, pain in the masseter muscle, and crepitus in both joints. If we see the X-ray, and this is a zoom of a panoramic X-ray or reconstruction, so it loses part of the details, but I want for you to notice that the shape is not exactly rounded. It has a weird shape. It doesn't have a good continuity, but the most important part, the height of the contour in the posterior area is almost the same as in the anterior area. And what you hope to have is that the posterior is much lower. So if both are almost at the same line, that means that there is a lot of remodelation on this joint. So why is that important and what I want to remember here? This is the cut of a condylar head. So you have all the cortical bone and fibrous connective tissue around. The disc is in the middle here. And then you have the temporal bone. Why I'm showing this diagram? Because I want you to pay attention to these little sacs. One sac here, one sac here, one sac here, and one here that I don't see, that I missed. So where the disc connects with the bony structures, there are little recesses. And all of that is covered by synovial lining. Just imagine, please, a sponge full of fluids. Imagine that for me, please. Why? Because every time that your jaw moves, those sacs are squeezed and that liquid is released. So every time you talk, every time you eat, you're actually lubricating your jaw. Now, thanks to that, you have some nutrition into the temporomandibular joint, and that allows to create something that is called adaptation. So remodelation on the jaw is okay to happen. It is okay to have remodelation because that means that, you are adapting to the whatever is needed from the function that you have. The problem is that sometimes that loading or that stress is not aligned with nutrition and lubrication, and you start losing through inflammation the cortical bone, or you start losing the characteristics of the subcortical bone. And in that case, you start having some breakdown of the joint with inflammation, and you have what is called arthritis. Now, is there any way that we can improve that? Yes, it is, because we can help with the lubrication of the joint. To do so, let's squeeze the sponge. And we will do that through using a simple exercise that is doing a hinge axis to make that condyle to rotate very fast and squeeze the sacs, the recess. So hinge axis like this. Move fast, the teeth don't touch, and that is called hinge axis and actually improves lubrication. Is it enough? Of course not. You will need some type of NSAID, some type of medications, and in many cases, we will need to use an steroid, but that helps. So if we are able to provide our patients with some type of supplementation of the synovial fluid, well, that's nice to do. And that is a way to treat and prevent problems in the temporomandibular joint. In these cases, please, please, please keep an eye on the range of motion. How much is the patient opening the mouth? Sometimes the amount of destruction or remodelation of the joint is not at all related with the range of motion or function of the patient. So if the patient can still open enough, even If the joint is completely destroyed, maybe your treatment plan will be different. This over here is a range of motion ruler. I have nothing to do with the company. I should show it like this. But this is a nice range of motion ruler that you can use. You can also use a regular ruler. It doesn't matter. It has to start in 0. This one has a little notch that I will put in the lower teeth, and then I ask the patient to open the mouth, and the upper teeth will indicate the range of motion of that patient. Very simple to do, and sometimes we forget. Another option is to measure your fingers and see how much your fingers measure. So I know, because I have calibrated myself, that 3 of my fingers measure 40 mm. So I can do like this, and I will say 40 mm. Please do that with all your patients. Identify problems with range of motion early. You will be able to provide a better service if you do that. You will have that documented in your chart. So next time that the patient comes, you will be able to identify if there is a change of range of motion. It doesn't matter if you are not a dentist. You should know how much patient can open the mouth. That will help you to identify arthritis at early stages. So please do that. If the patient has sounds like clicking sounds or crepitus, don't do them. Avoid them. Give the joint an environment to heal. Do a lot of hinge axis exercise. I already show you how to do it. And of course, you can use other strategies. And there is a little piece here that will help you for your patients. So you can give that to your patients as well. So where's the pain coming from? I show you 3 cases and none of them had pain. Well, maybe one, the peripheral neuropathy, but not related exactly with a cavity or with a periodontal problem. So there are many reasons. And saying that a patient has TMJ or TMD is not enough. We have to be able to identify what is that is going on, what is happening with our patients. So can a neuropathy produce dental pain? Yes, it can simulate a dental pain. It looks like a dental pain. So the patient might go to a dentist, and if the teeth is not very nice, it will have different treatments there. If there is an old amalgam, of course, that will be changed. So is that the source of the pain? No, that was the site, but probably not the source. What about muscle referral? Yes, perfectly possible that what you are perceiving as a dental pain is coming from the muscles. Let me tell you one weird reference pattern. Anterior fibers of temporalis refer pain to anterior upper teeth. Weird, right? But it is possible, has been documented. So if you don't do muscle palpation, you might be losing or missing a point with that case, and you are treating the patient for something that the patient doesn't need to. And of course, the possibility of having joint problems. And I know that you wanted for me today to address TMJ, and I know that you were expecting for me to talk about splints and about night guards, but I thought that it was probably more important to be clear and open all of us, our minds, to the possibilities of having several sources for the same pain, for the same area of pain. The relief of pain, I started telling you that, should be a human right. But that also means that we have to work together to try to provide the best care to our patients. So some of the patients will need for us to have a very good networking of professionals working with us, the physical therapists. Let me give you a simple example. If you have a patient in a dental chair, or if you have a patient on your office, and you will ask the patient to move the head to one side or the other because you want that patient, you want to inspect that patient, you want to see inside the mouth, or you want to see inside the ear, or you want to see that. So you are going to ask the patient to move the head to one side to the other. Have you checked the cervical range of motion? Are you sure that the patient has a normal bending? Are you sure that will be C1, Are you sure that the patient has a good rotation? That will be C2. Are you sure that the patient can bend? And that will be C2 to C4. To do that, you can use different resources, and you can actually measure using different things. Now, do I need to have this on my office? Do I need a goniometer on my office? Maybe no, but I do need to understand that I have to collect information, that I have to know everything that is going on with my patient in order for me to provide proper care. Let me remind you my email address, marielap@usc.edu. Feel free to write to me, please. And my ResearchGate, Mariela_Padilla_and Guevara. You can follow me there. But what I really expect for you is to be able to get some clinical tips from my presentation today and have an open mind on the multiple possibilities that you could have. Let me finish by showing you some an interesting place that I invite you to visit is our clinical webpage. It's called OFPOM Center, Orofacial Pain Oral Medicine Center .usc.edu. And that page is interesting for many reasons, but one is because we are including this little piece here that is called Clinical Pearls. So if you go to Clinical Pearls, you have a series of documents that are meant to be for educational purposes for your patients. For example, guided opening. If you open that and you give the patient that information, you will show the patient how to do a straight opening, guided opening at home. And that helps sometimes to provide or to improve some conditions related with muscles and related with joint disorders. Another example that I mentioned today was the hinge axis movement. So we created a small video that you see here. Of course, you can make it bigger. I will not do it because I don't want to occupy my whole screen, but I can show the patients how to do that. And in COVID times that we don't remove our masks, having videos is a way to go, believe me. Now we can explain them better how is that we want them to do the different exercises. Also understanding the jaw clicks. So here is some information for you as well. So I hope that with this information, you have some questions for me, either now or later. And I hope that I had addressed what the Armenian American Medical Society was expecting from me. And please, I would like to use the space now to get some comments or questions from the audience.
Thank you very much, Dr. Padilla. That was an excellent and very informative lecture. I appreciate it. So we're opening up the chat for any questions for Dr. Padilla, but before she answers them, I just want to let everyone know we're going to have the post-CME and CDE questions on our website. Hasmik was going to put the link up, so you can just click on it or go to the aamsc.org website and go under events. And you'll see, and you just click on April 19th where it says Dr. Padilla. Also, there is a $25 fee for non-members if you do want to get CME and or CDE credits. So just want to let everyone know. So we're going to go ahead and open the floor to questions. Let's see.
Well, thank you to Juliana, who's there, is one of our residents. So thank you for being here with us, Julie. You should have given the lecture, huh? And also we have a note from Garney. Thank you, Barkout. Don't know you, but thank you for your kind words. But I would like to have some questions. So let's see. Bring us questions.
There is a question, but it was earlier today at 7:35. It says, is it possible to produce more serotonin to help decrease neuropathic pain with your diet?
Mm-hmm. Okay, let's talk about modulation. Let's talk about modulation. I'm in severe pain, dental pain. I have been through several treatments. I have gone to several doctors. And now I heard that this doctor treats pain. So I'm gonna call that office to see. So I take my phone and call, right? That is the moment where serotonin starts from the provider point of view. Hello, how can I help you? May I help you? That conversation where the patient will feel, ooh, I think I'm in the right place. They do understand pain. So I'm gonna send you some forms. And then you see that those forms, ooh, quality of pain. So they understand pain. So serotonin starts from there. When you get into the office, you speak slowly. You don't rush. This is very difficult for someone like me that I rush the whole day. So I have to learn. I will speak slow. I will see you eye to eye. So all of those situations are actually excellent modulators, teaching the patient how to relax. Ask the questions. How you manage the stress? Are you doing some exercises? There are some supplements and complement medications, alternative medications that will help you as well with serotonin. And there are specific drugs that help with serotonin levels. And antidepressants like the TCAs, tricyclic medications, they work as well. They are not good for antidepressant. That's why we have new generation antidepressant. But TCAs such as nortriptyline, amitriptyline, those help. So yes, there are many ways to improve inhibition and modulation, and we have to be aware of them. I'm not saying that the pain is that the patient made up the pain, but I'm saying that we can actually contribute with some behavioral and cognitive techniques as well. I tried to answer it while I was talking, but yeah, not the same. Thank you, Lara. No questions? Geez, I didn't do my work well, Dr. Armond. No questions.
Great job. You answered everything. No, it was a fantastic lecture. Any other questions?
Okay, let me show one more thing before.
Sure.
Because I want to be sure that I give you enough resources. So the extra resource that I want to give you is this one, is our webpage. And I always like to say that the Ostro Online, Ostro On USC EDU webpage is a place to learn. It's a place to recruit students, right? I have to be transparent with that, but it is also a place to learn. So we created this area here that is called resources. And if you go to resources, there are several things there available for you. One is the insights. And in the insights, we have a series of blogs divided by category. And on each one of those categories, you will have a series of materials that are very, very useful. Short presentations, very well described, done by experts. So we have contribution by several doctors here, and those are very nice resources. So I invite you to take a look on that. Also, we have launched our Ostro Talk podcast. The podcast has several episodes already available for you. So if you want to learn on the go as you drive to the school or to the clinic, so we have several already available for you. And we are currently created more for you. So the Ostro Talk is our podcast channel. And finally, we have the downloadable free resources. And here we have some very interesting materials, such as the infographics that you can not only download, but also you can get a code to use those materials in your own webpage if you want to do so. And we have some guides, clinical guides for different conditions. I do apologize because for all of this, you do have to register. So you have to give your name and email address. You can unsubscribe later, but those are very useful resources. And I just wanted to let you know that they are available for all of you. Feel free to use them or ask for more.
Thank you, Dr. Padilla. There is a question from Daniela Caprelian. It says, do you use 1% lidocaine for trigger point injections, and how often do you recommend administering them?
When you do a trigger point injection, what you are looking for is to convert a taut band that is now chronic into an acute injury that will start healing. To do so, what you basically want to do is to introduce a stimulus that could even be a dry needle. You don't have to put anesthetic on it. It could be only the needle. However, we like to put some anesthetic there in order to start also to give the patient some comfort. We want to use an anesthetic that is not myotoxic. So we want to use the less possible toxicity or myotoxicity that is available. And most of the times we like to use 1% lidocaine, as you are suggesting. Sometimes you can use 2% lidocaine, but what it is important is that for the muscles, we get away from vasoconstrictors. Most of the dental carpals, they do have vasoconstrictors, and because of that, usually we like to get vials that required for you to draw the medication in a hypodermic syringe. So that is common in our field. We use a lot of hypodermic syringes. Actually, because of that, we are excellent volunteers for the vaccination program right now. So every Tuesday I go and draw medication. So we create vaccines for the people because we have expertise on that. So if you are not volunteering yet and you're interested in volunteering for the vaccination and you know how to draw medications, that's a place to volunteer. And to answer your question, yes, we prefer to use 1% lidocaine. Some practitioners will use mepivacaine, and that is possible as well, 3% without epi. Again, you could use the dry needle. How often do we recommend to administer injections? Geez, that's a nice question. Well, you know, when your computer stops working, the first thing that you do is you turn it off and you hope that when you turn it on, it will be working properly, right? That's what we all do. Same with the trigger points. Your hope is that blocking the area for a small period of time, it will reset the system. So your hope is that you don't need to repeat the injection several times. However, if the reason for the muscle to be contracted or the trigger point to be formed is not addressed, the trigger point will come back. So we do trigger points in patients who have shown adherence to our home-based therapy, moist heat packs, and posture, and end stretches. As soon as the patient is doing that, we feel confident that most probably the injection will produce a better result because now the patient is already having some type of additional therapy at home. With myofascial pain, I did mention to you, and I think you saw that diagram that I showed, there is a participation of the central nervous system. Inhibition and modulation is not working properly in those cases. And because of that, myofascial pain, differently than local soreness that will respond well to only moist heat packs and NSAIDs, myofascial pain in many cases require a medication that produces modulation. Who can tell me what medication is that? What is the medication that will help us with modulation and inhibition? I already mentioned it. So let's see if someone will write it down. I didn't put that as a question. I should have. Come on. A tricyclic. Tricyclic what? Good thing that I cannot point, huh? It is a tricyclic antidepressant. So very weird. Are you telling me, Dr. Padilla, that I should prescribe my patient a TCA for muscle pain? If the patient has myofascial pain with referred pattern, non-responsive to home-based therapy, your next path is trigger point injections and improve modulation. That improvement could be very conservative with cognitive behavioral therapy or pharmacological approach with a tricyclic antidepressant. Did I answer your question, Daniela?
Daniela is actually interested in orofacial pain residency.
Mm-hmm. Okay, we'll wait for your application. Okay, any other questions? And as I said, feel free to send them my way later. That's okay.
Let's see, so there's one more here. No, another thank you and an excellent lecture.
Well, we had it on Facebook as well. Let me just, oh my goodness, I'm hearing myself. Sorry, let me just check to see. Yes, we have a comment in Facebook. This is Sarmin Akashian. A lot of the concepts I cover in my physical assessment course will be the lecture link on my syllabus to students for review. Thank you again. Thank you, Sarmin, and feel free to use the other resources that I showed today that are on the webpage. We're currently developing some other things. We have an Orofacial pain wiki that we're launching. We already had the pilot running. It is running with our resident and online master's students, but most probably after research day is going to be launched to the public. So we have our own wiki that is going to be released very soon. So feel free to use that resource as well.
Wonderful. I think that is all the questions, Dr. Padilla. Again, we want to thank you on behalf of the Armenian American Medical Society and the board and all the members. That excellent lecture that you gave. I'm sure we'll see you soon.
Thank you very much. Thank you for the invitation, and thank you everybody for bearing with me.
Thank you. Have a good evening.
You too. Bye-bye. Good night.
Good night, everyone.